Welcome everyone. We are really excited to be here today at the launch event for the Australian Society of Psychiatrists. Before we start, I just want to acknowledge, to do an acknowledgement of country. So I'd like to begin by acknowledging the traditional owners on the lands which I'm speaking from today, the Camaragal people of the Eora Nation, here in St Leonards in Sydney. And I pay my respects to the elders, past and present, and I extend that respect to all First Nations peoples joining us today from the many lands where you're tuning in as well. For those who I haven't had the pleasure of meeting, I'm Pramuthi Gunaratna. I'm a New South Wales-based psychiatrist and the Executive Director of the Australian Society of Psychiatrists. One big question we've been asked since ASOP was introduced is, where did this whole idea come from and why do we need this society? And I hope that this will become clear as we continue over the next hour. So first I'll go through an overview of ASOP and then we'll have time for some questions from the audience. So please feel free to type into the Q&A section and our board will then answer as a panel towards the end of the session today. So before we look forward, it might be helpful to take a look in the rear vision mirror a little to understand how all this is unfolded. I'm not sure how closely those tuning in have followed the goings on in New South Wales, but we've had a pretty big upheaval in our mental health system. And through that process, we've learned a lot about advocacy, the need for advocacy, the time and effort that it takes, and the potential that it has to make huge change. And while this story started in a single state and focused mainly on the public sector, it's clear that we have a national crisis in mental health and that the problems extend beyond just the public sector, but into the private system, primary care, NGOs, and how all of that connects and often doesn't connect. And we've learnt that there's a lot that we could do as a profession to step up, to advocate for better quality of care, but also to advocate for our profession and the critical work that we all do. And so we were a group of random individuals. Some of us held college roles, some of us held ASMOF or AMA roles, some of us had no official roles at all, but the work that was done occurred when we all came together, and it was a completely grassroots movement, completely independent, and a lot of the funding was crowdsourced by individual psychiatrists pitching in. So while there are many lessons that we've learnt, one of the big ones was that there is a huge possibility for remarkable cut through, even with a small group of individuals. And the headlines in this slide are just a fraction of the total. And while we thought initially that we might be crushed by stigma and negative sentiments, surprisingly, the public really got behind us and people understood that the mental health system needed some serious work. And that psychiatrists can be powerful advocates. And so for those who may not be so familiar with some of what occurred, we'll start with a short video that again just captures a few selected highlights from that story.
These psychiatrists want you to listen. Scores have resigned this year, shattered by the public mental health system in New South Wales.
One of our first principles is first do no harm. And when you feel you're in a situation where you have the potential to do harm, it's probably time to go.
Intolerable conditions have forced them into life or death choices.
He was walking around with a loaded nail gun in public. It's another Bondi junction waiting to happen.
And people who need this system are stuck in a vicious cycle, in and out of hospital.
They said to me, we can't do anything because the beds everywhere were full. So they just had to send me home.
Australia is facing a national mental health problem.
We still have no tangible action from our government. So it really, I have no idea. What will it take for this government to take mental health care seriously in this state?
Dr. Pramuthi Gunaratna is the chair of the Royal Australian and New Zealand College of Psychiatrists. She says at the heart of the crisis is a critical workforce shortage.
You're in crisis all the time. You are managing crisis. You are not contributing to therapy. You're not contributing to meaningful care.
Psychiatrists can't keep propping up a broken mental health system. In some community teams, we have a single psychiatrist who might be covering hundreds of patients. And when you consider how unwell these patients are, how much care they need, it's really unsustainable.
From your view, is that safe for patients?
I don't think so.
Doctors say the mental health system's in a catastrophic decline, with nearly a third of psychiatrists' positions unfilled. Dr Catherine Drew is among about 200 who are now quitting in protest.
Our patients are not receiving the care that we believe would be appropriate.
Last year, a 7 News investigation heard from patients and staff from the state's largest psychiatric facility at Cumberland, reporting violence and a critical lack of resources.
This is the worst it's ever been. Services that were there 20 years ago are just completely gone now. We can't just have things getting worse and worse.
It's just a call for action.
A broken mess. That's how Sarah Logan describes the public mental health system as a patient over the past 10 years.
It'd be a game of Russian roulette as to what happens.
Consultant psychiatrists are specialists with critical expertise in mental health treatment.
When people think about what a psychiatrist is, they probably imagine someone in a suit sitting in a fancy office talking to someone about their feelings. But that doesn't actually reflect a lot of what psychiatry is, particularly in the public system where we care for people with some of the most severe mental illnesses like schizophrenia, bipolar disorder, severe depression, people who might be at risk of harm to themselves or other people.
We know that 50% of mental health conditions present in children before they turn 14. And so there's always the hope and the opportunity that by intervening early in a child's life, you're able to improve the life course and the mental health, but also the broader health of a human being for many years. But where that intervention happens too late, I suppose you miss the boat.
Tell us why... Is that a silly question? Why are teens drawn to risky behaviours, or have they always been?
No, not at all. This is something that, I think we all know from our personal experiences that teenagers tend to engage in a lot more risky behaviours, and the reasons for it are complex, but one of the big drivers is actually brain development.
Mental health has the second highest disease burden in Australia at 15%, just below cancer, which accounts for 17% of our disease burden. But mental health care receives just 5% of the health budget, while cancer receives double that. And we really need to fix that and fully fund mental health care if we want to have the same world-leading care in mental health like we do in cancer care.
I hope that gives a little bit of an idea of what the last year in New South Wales has been like for psychiatrists here. So when I did my public health training, we learned about policy windows opening up. And it feels like right now we might be in one of those times where a policy window has opened up for change in the mental health care system. Journalists and the public are listening, and as psychiatrists, we can step into those spaces. This is a story hot off the press from today's The Australian newspaper. Not only does it showcase the launch of ASOP, but it also highlights a report released by the AMA today, their Public Health Report, Mental Health Edition. And I'm very grateful to Daniela McMullen, Federal AMA President, for her support and for sending us this advanced copy so that we could share some of the stark findings at our launch today. And we'll also be in Radio National tomorrow discussing ASOP and the stark findings from the AMA report. But if we look at some of this data, drawing on AIHW data, the report shows what we already know, which is that the system has been going backwards for decades. Here we can see that Australia has experienced a long-term decline in the number of mental health beds available per person over the last 30 years. The latest figure, 27 per 100,000 Australians, is the lowest on record. And this graph doesn't even account for the beds lost during deinstitutionalisation, so it's all post-deinstitutionalisation. This decline comes at a time when demand for care is at an all-time high. So 20 years ago, 69 of every 10,000 presentations to Australian emergency departments were for mental health reasons. Now it's closer to 115 per 10,000 presentations. That's a 67% rise in the last 2 decades. The data shows that not only are the presentations more numerous, but they're also more complex. The proportion of patients requiring admission is increasing, and there's significant growth in both urgent and emergency cases in these presentations. So taken together, the demand for mental health care is at an all-time high, but the system capability is at an all-time low. And I think we all know that ED is just the tip of that iceberg. EDs are a place of last resort, and increased pressure here is a sign that the rest of the system is buckling with insufficient community care and early interventions. So what's the problem? The first is underinvestment. There's a huge funding gap. Depending on where you look, investment into mental health care is somewhere between 5 and 7% of the health budget, but our disease burden is 15% of the total disease burden in Australia. So we have the second highest disease burden, but we come 6th in the league table for investment. So funding is clearly disproportionate. And we often in psychiatry circles talk about how we might be able to split the pie in different ways and how we might be able to do things differently. But really, we also need to push for the growth in that pie, for more investment at the state, at the federal level, and in terms of private investment. And we think that we need to be much more bold and deliberate in doing that. The second problem is around misunderstanding, and there's a series of these misunderstandings in mental health care. People don't often understand what serious and complex mental illness is. There's been destigmatization of some diagnoses like ADHD or mild to moderate depression, but things like schizophrenia, bipolar disorder, severe depression are not well understood. Most Australians would recognise what a heart attack looks like or what a stroke looks like, but I don't think many would really be able to identify a psychotic episode. And most Australians don't know what psychiatrists do. I think many of us would be familiar at turning up at social events or dinner parties and saying that we're a psychiatrist and people not recognising that that's even a medical doctor. In New South Wales, we had our Premier calling us psychologists, and he wasn't called out on it because most of the public probably didn't understand what the difference was either. And then there's the stigma and nihilism. There's so much questions that we often get in this space about, can things get better when someone has a diagnosis like schizophrenia? Will more investment help? It's full of hopelessness and negative stories, but we, being on the coalface, we can speak to the potential to change the entire trajectory of a young person's life when they do have access to high quality care. And we can help to dismantle that nihilism. The third problem is that we don't often have a seat at the table. We don't have a strong voice in the media as a professional body, and we don't have strong engagement with government because there's limited connectivity. And when there's a vacuum, others work to fill that void. So media and government will often turn to specific individuals or to other groups. And then funding often in mental health goes into interventions that often have a limited evidence base or limited measures of success. A very recent example of this was our professional organisations all being bypassed in policies related to stimulant prescribing. During that policy change, psychiatrists were painted as being expensive gatekeepers, preventing people from accessing care. And unfortunately, there wasn't a strong voice to explain what we do and the potential risks without specialist oversight. This is a complex issue, but I don't think that as psychiatrists, we got a fair hearing in the public discourse or the policy debate. So what are we proposing from ASOP? Well, there are 3 pillars of initial work, and I have to acknowledge that we're still in the very early stages of forming and we'll develop a lot more detail around this. But the first area of work that we want to focus on is around public-facing advocacy. We need to fill the void that's there and make sure that there are psychiatrists and expert clinicians across media, from mainstream breakfast television to investigative pieces and having a social media presence, so that we are speaking to the evidence and we are speaking to the expert consensus. We want to build an army of media-trained psychiatrists and trainees to step up and show who we are and to provide that expert opinion. We also need to balance our core messages around mental illness, the role of psychiatrists, and equitable funding with being agile and responsive to issues as they arise. And being a smaller, very much less sort of bureaucratic organisation, we have the capacity to be able to do that agile, responsive work and achieve proper cut-through and presence and respect for our profession. We also want to make sure that we're engaging in political advocacy in a very deliberate way. We want to build relationships with allies in government, whether they're politicians, staffers, or bureaucrats. We want to make sure that we're entering the right rooms, that we're educating policymakers about mental illness and about the system. And we're very lucky to have two exceptional patrons who can help us in entering those right rooms. And we want to work with our board to be strategic in deciding on the issues that we want to tackle and how we can step from there and build out. And we'll also be engaging with our membership to understand what the important issues are. Finally, we recognise that we can't do this alone, and we need to build alliances. We represent psychiatrists, but we also need to work across the sector with lived experience, carers, NGOs, allied health. We also need to work across medical specialties with the AMA, with other societies, with colleges, with specialist groups, so that we're all working together. And we also need to be bold in getting out of our comfort zone and looking at how we might be able to engage non-traditional actors, because change requires bringing people along who are committed to working together. So with that, introducing our two wonderful patrons who we are very honoured to have as part of ASOP. They've both provided some statements for me to share at this launch. We'll put the full statements on the website, but here are just some excerpts. So first, from General the Honourable David Hurley, former Chief of Defence and Governor-General of Australia. From my interactions over the past 2 decades with Australians, particularly veterans who have experienced trauma, I'm pleased that you have placed your emphasis on improving care for those with severe and complex mental illnesses. We must do better in the provision of quality care that is continuous and does not leave sufferers at risk. In your work to achieve this, you will also demonstrate to Australians the importance of your profession to the nation's mental health system. I wish you a successful launch today as you begin work that is vital to our nation's future. And from Professor Alan Fells, former ACCC Chair and National Mental Health Commission Chair, I'm proud to serve as patron of an organisation that will undoubtedly elevate mental illness on the Australian agenda. There is so much work to do in tackling our mental health crisis, and I have no doubt that ASOP is well placed to achieve a stronger voice for those with lived experience, their loved ones, and indeed our mental health workforce. And we look forward to ongoing relationships and working closely with both our patrons. And I'm incredibly proud to introduce the brilliant board who will be leading ASOP through these first steps. You can read everyone's full bios on their website, but the calibre, the diversity in terms of subspecialist areas and geographic spread of our board is incredible. So from New South Wales, we have Associate Professor Beth Coetzee and Dr. Catherine Drew. From South Australia, we have Professor Taryn Bastian-Pillay. From Victoria, we have Professor Chris Davey and Associate Professor Andy Carroll. From Queensland, we have Professor James Scott and Professor Steve Keisley. From regional Australia, working across 4 different states in the last year, we've got Dr. Deepika Yerakalva. Providing a lived experience voice on our board, we have the wonderful Sarah Logan. Taking up the trainee position, we have Dr. Amy Corduroy. And part of our executive is Mr. David Factor, who'll be leading in our public affairs space. So this is an incredible all-star team, and you'll be able to hear more from them when we get to the questions and answer part of today's launch. Our constitution is also available on the website, and we've built in retirement cycles so that we can refresh a proportion of the board at each AGM, but maintain continuity as well. And so members will be able to vote once this begins. But initially we thought it was important to have an appointed board so that we could hit the ground running and start doing the important work that we need to do. I also want to acknowledge the incredible work of our founders who have spent many, many hours working tirelessly to build the society. Some are on the board or have taken up positions in the organisation. And then there are the selfless warriors who have worked behind the scenes to build ASOP. And I think this might be the elephant in the room. You know, what about our college? I think we all agree that colleges play a critical role in training the next generation of specialist doctors, in accreditation and maintaining professional standards. And I don't want to diminish their role in any way. But the reality is that there are lots of limitations for colleges in terms of advocacy. All colleges are under threat at the moment. The business model for a college or the reason for existence relies on government safeguarding colleges' special roles, their special roles as gatekeepers for training, their role in specialist recognition and in professional development. But all those are currently under threat. CPD homes have been introduced, which means that colleges no longer have a monopoly on that. The Medical Board of Australia have developed an alternative pathway for international medical graduates, which bypasses the college. So that's no longer protected. And the college has a range of conditions in place from the AMC around training. So colleges are rightfully not feeling secure with upsetting government and engaging in unencumbered advocacy. And that's not just the RANZZP, but across the board. Second, colleges have multiple priorities. Our college is doing a huge piece of work in terms of the seismic shifts that are occurring in the training space, which takes a lot of their airtime, and rightly it should, because this is the core role of a college. And I think we'd all really appreciate that our college doesn't take their eye off the game when it comes to this space. So it's really hard to venture into these totally new areas, especially when over the last few years our college has been managing an operating deficit. And so this is not really a period of growth to enter into a new space. And I hope that none of this is seen as throwing shade on the college. It's just the facts. And I hope that in some ways it might explain why the college, why it has been tricky for the college and all colleges to engage in advocacy. And the ideal situation would be a college that works independently but hand in hand with the society, each playing to their strengths and elevating the profile of psychiatrists so that our efforts are really complementary. You know, lots of colleges co-convene conferences and have memorandums of understanding with their respective societies. And a question that's often asked of us is, will this dilute the voice of psychiatrists? We really think it's the opposite, that what we'll see is a concentration of our voice as a profession, because we will have a dedicated body to advocacy with a very determined scope to provide our profession with a strong voice. And we aren't the first group to come to the realization that we need the right tool for the right job. The idea of a society, it's not radical, it's not new. We're actually just following what has been best practice with other medical specialties across Australia. So we have the Australian Society of Anaesthetists, which works in tandem with ANZCA, the college. They've been in existence for 91 years and have over 4,000 members. We have ANZICS with the Intensive Care College, again in operation for over 50 years, have more than 1,200 members. The Society of Ophthalmologists existing beside Ransco, the college, 43 years and has 75% fellows as members. The College of Surgeons has multiple societies that they work with, but one big one is the Orthopaedic Association, again in existence for 88 years with over 2,000 members. College of Physicians similarly has multiple societies it engages with. One that's much newer than the rest would be the Rehabilitation Medicine Society, in operation for 15 years, has over half their fellows and 75% of trainees as members. And one day, perhaps, this can be our story too. Each organisation playing to our strengths, working for the betterment of our profession and for the quality of care that we deliver to our patients. Maybe 90 years from now, this will be a totally normal fabric of our landscape too. Looking ahead, some exciting potential developments for us as a society and for our membership. One of the really successful things that many societies have been able to do is to build registries so that they can do data-driven advocacy. The ICU Society, for instance, has an incredible registry which captures every ICU in the country. And they have outcome data, objective measurements from patients, as well as patient-reported outcomes. They look at things like resourcing in different ICUs, and so that they can identify outliers and do proper data-driven advocacy. Similarly, the Australian Orthopaedic Association hosts a joint replacement registry. This started in 1999 and captures over 2.3 million procedures. Now it's seen as a federal quality assurance activity. And we're really excited that the ICU Society has offered to partner with us to support us in developing this sort of tool for our profession when the time is right. We think it's really important to understand what's going on out there because data gives us a lot of power in terms of bringing about change. One of the first activities that we're hoping to do is to launch some workshops across the state so we can canvass local issues. We know that big picture advocacy is important, but we can't drive things unless we have narratives and stories and local issues to build that momentum. And we also want to provide media training to build our pool of psychiatrists and trainee spokespeople. We're also really excited about some fun, quirky, interesting event ideas that we have in the bag. We know that we're stronger when we're connected, particularly post-COVID. I think we've become out of that practice of that in-person contact. And so watch this space when we'll launch some really fun ideas coming your way. But we can only do this together. So we need you. We need the more members we have, the greater mandate we have to do this work and to truly become a collective voice. Your membership fees will go towards our establishment costs, towards staffing, and towards the different services that we'll need to contract to do the work that we've set out to do. We're going to keep it really lean and mean and agile so that we can be responsive. And of course, we're going to be as transparent with how that funding is being spent. So that is enough from me. I'm going to stop my screen share and hand over to Amy, who's going to lead the question and answer part of this launch.